Our topic is an update on preventive treatment gels and toothpastes. Hi, my name is James DiMarino. I'm a licensed dentist as well as a professional educator working at Premier Dental as a Director of Clinical Affairs. So what I'd like to do tonight is take a brief look through our learning objectives. One of the things that we're going to look at tonight is to evaluate the prevalence of common dental conditions, identify the specific benefits of sodium fluoride, stannous fluoride, and sodium monofluorophosphate. Let's understand the concept of bioavailability and discover the differences between calcium phosphate technologies. Recently, the ADA came out with a report on toothpaste usage for young children based on age. So we're going to review that as well. And our ultimate goal is to help dental professionals identify which oral home care product features may be most appropriate for various dental conditions. So I recently was at the supermarket and I looked at the toothpaste aisle, and what I saw was a lot of different colors, a lot of different products. And what's interesting is I said to myself, I wonder what toothpaste most dentists use at home. And then I said, well, I wonder what toothpaste most dentists recommend patients use at home. And if that recommendation gets from the office to those shelves in those stores, and they can discern the difference between all these different colors and claims and pick the appropriate toothpaste. So I want to start there and include a poll. So we're going to do a couple of different things tonight, and one of them is to include polls in what we're in our presentation. So let's real quick just take a minute here and answer this question for me, if you would, just to help us get an idea of what everybody's thinking out there. Which toothpaste is the one you most often recommend for your patients to use at home each day? And I find this interesting because even though we have recommendations, a lot of times we go to our patients and they come back 3, 4, 6 months later and we ask them, well, did you use that product we asked you to get? And sometimes, oh yeah, I used it. And what was the name of it? And they'll forget the name, or sometimes it's not the same product that we recommended. So I find it interesting that we're trying to discern whether or not anything gets lost in the translation. So the numbers are coming in, and it looks like we've got almost everybody. I'm going to give everybody about 5 more seconds so we can kind of get a good poll here. I thank you all for your help in this regard. So let's take a look at our results. A couple more coming in. That's great. And right now it looks like Colgate Total is the winner. So that makes sense. And what this is, we're trying to figure out tonight is what are the trends that we're seeing with our patients and what they're currently using and what we're also asking them to use. So one more poll, if you will. What are you currently dispensing or selling to your patients in your office? Meaning patients come in, they may have a condition that you want to prescribe a 5,000 parts per million toothpaste, or maybe they have sensitivity, or just to get an idea of if you dispense any of these products in your office. And obviously some might not be listed here, but if they're not listed and they fall into one of those categories, a remineralizing product or desensitizing product, just select that choice. What we're trying to do is figure out how offices help their patients through these different types of products. Obviously, we're getting flooded with new products on the market, and one of my main challenges and concerns as a clinician is to say, well, what products should I be prescribing or recommending? How do I evaluate these products? And truthfully, what makes one better than another? Or are they all just the same? So let's look at these results. So it's interesting. You know, we seem to have a fair distribution of different products that are being dispensed through the office. So if we're dispensing these products through the office, or we're recommending that patients use a certain product, does it really matter what our patients use at home? Because we're actually engaged. In the previous 2 polls, it seems we're very engaged in either recommending a product or prescribing a product. But we're really relying on those patients to use those products. Number one, they have to get the product that we recommend, and number two, they have to use it. Otherwise, our recommendation falls short of providing the results that we're looking for. So the question is, does it really matter which products our patients use at home, whether we're recommending them or prescribing them? And I think we also have to look at the fact that, well, we only really get to see them in the clinical setting twice a year. Sometimes more if they've got different issues, but on a preventive basis, could be 2, 3, or 4 times a year, depending on the condition. And that's if we get them back every 2, 3, 4 months, as we recommend. But at home, they're doing something, hopefully, at least twice a day. That's our goal. So if we can give them something that they can use that's going to help them at home with a condition that we've identified in the practice, obviously that's our best connection. So let's look at this in a different way. If we've got patients presenting with some concerns, caries, gingivitis, sensitivity, let's poll our group again and see how many or what percentage of your patients present with one of these conditions. So you can answer multiple times. The question is, how many, do you see patients with caries? Do you see patients with gingivitis? Do you see patients with, or actually I think the poll is set up that you can only pick the predominant one. So I guess the question now will be, which is the one you see most often? And it's exactly right. The numbers are coming in primarily caries, followed by gingivitis. Actually, they're almost in order. Sensitivity, then dry mouth, and orthodontic white spot lesions, and gingivitis. It's a concern that we see even if we don't do orthodontics in our office. Perhaps there's referrals and the patients come back for the cleanings in our offices. We notice that there's a high incidence a lot of times of gingivitis associated with orthodontic brackets and treatment. So let's look at this one. And that seems to be appropriate, right? We see a lot of patients in our offices that present for caries, then gingivitis, then sensitivity. So it seems to be a consistent flow that we're seeing in these polling data. So let's look at the statistics. So you were right on, caries. 31% of our periodontal patients over the age of 60 experience root caries. Pedo patients, this is a number that was shocking to me. 41% of children have caries in their primary dentition, and 42% have caries in their permanent dentition. In this day and age, a lot of different options, a lot of different therapies. We would hope that those numbers would start to decrease. And let's look at sensitivity. A lot of times we have patients that present with, I know in my office, I'm not sure that we ask about sensitivity. So if you do ask your patients for sensitivity, let's get a number here and see how many of your patients that you see on a routine home care and hygiene appointments present with a concern about sensitivity. And ask yourself if that's something that we even query them when they're in the office. There's so many different things that we can ask them now. We've got all these different assessments and different ways that we can look into trying to help reduce the amount of caries, and clearly the last poll showed that that's our primarily what we see in the office. But I just wanted to take your temperature on what you see in your offices as far as patients presenting with sensitivity, because I was actually staggering when I saw the results as far as the research. So again, you've all been very consistent here. About almost 63% say that 25 to 50% of your patients present with sensitivity. That's right on. You're going to see here sensitivity with patients. 25 to 30% of the adult population suffer from sensitivity. 57% of the general population, and this is a staggering number, but it makes sense once we look at it. 68 to 98% of periodontal patients. Well, that certainly makes sense. The peak onset is between age 30 and 45. Women are slightly more affected than men. Maxillary teeth are affected to a higher extent, and buccal surfaces show the highest prevalence rates. So let's keep going. Let's take a look now at orthodontic patients. So let's just do a quick poll here. of your orthodontic patients, what percentage do you see develop white spot lesions? And again, these don't have to be patients in your practice that you perform the orthodontics for. It could be a general practice office where you refer your orthodontic patients out and they present with, come to your office for your routine hygiene appointments, and you start to see that progression. And I know for me, that's one of the frustrating things about orthodontists is if I start to see those decalcifications occur, I'm very concerned. Obviously, we think we're going in the wrong directions if we start to see areas of decalcification. If they progress to a white spot lesion, that's certainly of great concern for a lot of us. So let's look at these numbers. Again, right there, 51.9%, less than 25% patients present with white spot lesions. But then you get to that 25 and 50%, and 50 to 75%. These are strong numbers suggesting that we might be able to do a little bit more for them. So let's take another look. This is your typical presentation for a lot of our patients, and unfortunately, I know for me, and I'm sure a lot of you, we wish we could do more for them. When you see the outline of those brackets, outlined by decalcification, that's a major concern that we really want to try and avoid. The healthy part of the tooth is the place where that bracket was bonded to the tooth structure and protected from the acidic attack. So 25 to 50% of all orthodontic patients develop white spot lesions. So what you're seeing in your practice is statistically relevant to what the research is showing. What I thought was interesting is 97% of all orthodontic patients experience decalcifications. Now the good news is they don't all progress, obviously, to white spot lesions because only 25 to 50% of those progress to the white spot lesions. But we've seen it before. We've had a lot of patients who present, they've got the gingivitis, increased level of gingivitis and bleeding upon probing, got the plaque around the brackets, you start to see the decalcification, and then you worry and you go over hygiene and you hope that they don't progress to white spot lesions. Dry mouth. I know this is a difficult topic for a lot of us. Not something we'd like to see, and we really hope that our patients don't have to experience this. But let's take a quick poll on this. I was surprised that when I saw the numbers here as well. There's a lot of reasons for dry mouth, but it's not something that I typically asked about. Obviously if you do an intraoral exam and you see a sharp decrease in saliva, then it prompts me, but a lot of times there's a reduction in salivary flow. Not necessarily complete dry mouth, but enough of a reduction that's uncomfortable for patients, and they might not bring it up. So when I saw the numbers at this point for dry mouth, I thought that's something that we needed to share. So you were right on as far as where I was. I thought it was less than 25%. I really didn't have a number in my mind as to what I thought would be a clear indication of patients with dry mouth. And there you go. 21 to 27% of the population suffer from dry mouth. You're right on. 3.1 million Americans suffer from Sjogren's syndrome. And the number that we've all seen probably many times is polypharmacy, where you've got patients taking multiple drugs or drugs that potentially cause dry mouth. 50% of the United States population takes a prescription drug, and 75% of those prescription drugs cause dry mouth. What's further intriguing is it's not just the adult population where you would assume with the high blood pressure, high cholesterol, depression, but then you get into the adolescent and child populations with asthma, ADHD, ADD, and these are just a short list of what we're seeing as far as drugs that can cause dry mouth. So what we're getting to and what we're starting to try and put together between polling you and then showing you the research is that there are a lot of untreated conditions. And in dry mouth, it's a perfect one, and I know I'm guilty of it as well. Dental professionals do not always have the confidence to discuss dry mouth with their patients. I've tried different products. I know it's so uncomfortable for them, and I struggle to try and find something that's going to be helpful to them. How about acid reflux and GERD? Gastroesophageal reflux disease. Have you seen patients like this in your office? Again, your heart goes out to them. You start to see the pitting. You start to see the enamel wear across the incisors and lingual surfaces. 10 to 20% of the population suffer from GERD. Yet up to 59% of the population reports heartburn monthly. So there is a discrepancy there. That tells us that there's an undiagnosed patient population suffering from GERD and acid reflux. 18% use prescription drugs to manage their symptoms, and 49% of those 3.1 million patients who suffer from Sjogren's syndrome have GERD. When you put those two together, that's a very, very uncomfortable position for them to be in. Again, another undertreated condition. In this case, it requires greater awareness and collaboration between our dental and medical professionals. How about erosion? When I think of erosion, I honestly did not think children. But, unfortunately, there is a link. Acid erosion in children. There's many studies, but one I chose to share with you tonight is a 5-year longitudinal study reporting that 71% of children had erosive lesions of at least grade 1 in their primary dentition. 26% had grade 2 erosions in their primary dentition. And 12% of 16-year-olds had at least one permanent tooth with grade 1 erosion. Now, I'm not sure how many of you are familiar with these different terminologies, but I chose to include the definitions here, and you can see that when you get to the point where you're looking into the pulp chamber, there's not too many restorative options for patients whose erosion has progressed to this point. Same thing for toothbrush abrasion. Chemical erosion combined with toothbrush and toothpaste abrasion can remove all the enamel, leaving only the dentin exposed. There's a lot of problems out there in what we're experiencing with acidic drinks. We have intrinsic and extrinsic sources of acid challenges. But when you soften the enamel and then you use an abrasive toothpaste or toothbrush, the abrasives that are common in many toothpastes, coupled with a vigorous brushing, can damage and result in a unique sandblasted effect on tooth enamel. I'm sure a lot of us have seen this. And our hearts go out to these patients because we know there's not too much we can do. It's very difficult to bond. It's very difficult to get to relieve the sensitivity. But one thing I find paradoxical is that patients who sometimes abuse toothpaste typically dislike the color of their teeth. And they're doing this because they have a mistaken belief that the more they brush, or the whiter the toothpaste, or the higher tartar-controlled toothpaste, the whiter their teeth will be. When in actuality, what they're doing is wearing down that outer layer of enamel. And as that enamel thins, they're exposing the yellower dentin that will actually make their teeth look darker. So there's a challenge here for us because very few dentists are aware of this slow, insidious destruction that we're seeing through all the acid challenges and then coupled with some of the other products that patients are using. So there's things out there that we can identify now and hopefully try and help our patients by proper recommendations and assessments. Fluorosis. Now this is an interesting point. 8% of 12 to 15-year-olds have had mild fluorosis and 5% have had moderate fluorosis. The key is that dental fluorosis in the United States has increased during the last 30 years. So a report that came out in 2010 showed that there was an increase from 22 to 40% fluorosis rate between 1986 and 2004. Now, how can this be? We've got a lot of different products on the market that contain different sources of fluoride. So there's an overlap that we have to be aware of so that we understand what we're recommending and taking into account different sources of fluoride for our patients. So here's an internal poll, if you will. How much toothpaste placed on a toothbrush do you swallow? I thought about that, and the research is showing that 10% of the toothpaste that we put on a toothbrush as adults gets ingested. So what would that number be for children? And obviously there's a big difference between a 3-year-old and a 6-year-old and an 8-year-old, but on average, what would you think? Just take an internal poll for yourself. What I found was up to 48% of what you put on that toothbrush is ingested by those children. And I've seen other research where children under the age of 3 swallow almost 75% of what you put on their toothbrush. And I've seen it many times where, if they like the taste and they like the process, they'll, swallow a lot more of the toothpaste than we would like them to. So these are all concerns that we're starting to address now that really have been lying below the surface. So knowing that, we're challenged to come up with therapies that target certain conditions. And with the prevalence of new products entering the market, how do we assess which product might be an appropriate therapy for our patients? Well, obviously, like you had all had attested to earlier in our polling, dental caries is our primary concern, and it's what we see most often. But we've also extended those concerns into plaque and gingivitis, hypersensitivity. Now we're looking at erosion, xerostomia, fluorosis. There's a lot of different things that we have to be concerned about now, and we have the ability to look into research and find ways to help our patients. So what would desirable features for a preventative treatment gel and toothpaste contain? Well, they would need to be effective. We would like them to be long-lasting. We would like it to be safe for all age groups. Low abrasivity would be a concern, I think, that we might want to include. Easy to use, pleasant tasting and texture, and multiple benefits, meaning if we could find a product that crossed the platform and took care of caries, gingivitis, sensitivity, and some of the other concerns, that would be a good product. As we all know, compliance is a difficult thing, especially for our ortho patients. So the more products we put into their hands and require them to use decreases compliance. So here's another internal poll. Are all sources of fluoride the same? And this is something that was very interesting as I was doing some more research and learning through my years in practice. If I said to you stannous fluoride, sodium monofluorophosphate, first thing that comes to my mind when we say fluoride, anti-caries. So they've all been proven to provide anti-caries benefits. But we've seen a recent wave of stannous fluoride products coming onto the market, and I should say re-emerging into the market, because stannous fluoride was a predominant or a popular fluoride source that had gone away for a while. But now it's coming back, and what we can see with the status is it provides an additional benefit of anti-gingivitis. And additionally, it's the only other source of fluoride that provides sensitivity relief. So when you look at this, it starts to come together, and it says, well, wait a minute. Based on what I'm seeing with my patients, would they benefit from a product that contained that had an anti-caries benefit, anti-gingivitis benefit, and provide sensitivity relief? Maybe. So let's look a little bit more at these numbers. Efficacy against caries. Well, we just mentioned that all fluoride sources were effective against caries. And it's effective in fighting caries for children and adults. It's effective for coronal and root surfaces. So there's plenty of clinical trials and studies showing the efficacy of fluoride against caries. So we're clear on that. So all of them provide caries protection. Now there's a product out that we all know, I'm sure, or at least heard of, I hope, is the prescription level 5,000 parts per million fluoride toothpaste. Now they've been proven effective for root and coronal caries, but they're not intended for treating dental sensitivity. But interviewing dentists, you might see that some use it in that capacity as well. So what does this all mean from a caries protection standpoint? I thought this was interesting because we've got a lot of different fluoride products. And I was hoping to present to you one slide that brought them all together. When I look at this slide, I look at this orange line in the middle, or slightly off center, and where that falls is 1,500 parts per million fluoride. And that's the line that the FDA says anything below that line, any toothpaste below that line can be considered an OTC, over-the-counter product. Anything above that must be used by an office, by a dentist in an office, or is a prescription product. So when you look at the left side here, we see our sodium fluoride rinses, our stannous fluoride gels, our sodium fluoride toothpaste, and then we see our stannous fluoride toothpaste. So everything on this side of that orange line are products that we provide to our patients to use at home. Now on the right side, we have this hybrid sitting here at the 5,000. Now this is a prescription product that, if you look here, crosses over, and we rely on our patients to use this product at home. Then we've got our gels and foams, and then we have our varnishes that we provide for our patients in our offices. So why is this important? Well, remember when we asked that question, does it really matter what they use at home? And we came up with the conclusion that, well, we have these tools in our bag to use in the office, but we really only get to see our patients maybe 2 times a year. But if we can get a product to them that they're going to use 1 to 2 times per day, and it's going to provide the benefits that we want them to have, then that therapy over time could potentially be a greater impact than what we do in our office for prevention. And again, the crossover here is our 5,000. We're going to rely on those patients to use a prescription product at home. And that's where it comes to patient education and providing them all the tools they need to make sure that they follow our directives. Now, I mentioned this earlier. Here's a slide that we're going to just take a quick look at, last one on our caries section. But this is important, and I thought it was worthy of its own slide. And as I mentioned, the American Dental Association Council on Scientific Affairs came out with a fluoride toothpaste use for young children recommendation just this past year. And what they did was something very intriguing. If you look, they broke it out between children ages 3 and under 3 and children ages 3 to 6. Now, I find it interesting because they gave you all different sorts of ways to figure out how much toothpaste is appropriate. They tell you it's 0.125 grams for children under the age of 3. I don't know about you, but I'm not very good at dispensing 0.125 grams of toothpaste on my toothbrush for my 3-year-old. I really don't know how to do that. So what they did was they say caregivers should begin brushing children's teeth as soon as they begin to come into the mouth by using a fluoride toothpaste in an amount no more than a smear or the size of a grain of rice. Well, that makes sense to me now. I get a visual of what a grain of rice looks like. I'm not going to go get my scale and measure 0.125 grams. I'm going to dispense a smear, which in my mind is going to look like a grain of rice. So the next one is a pea-size amount for children ages 3 to 6. So caregivers supervise children's brushing to ensure that they use the appropriate amount of toothpaste and minimize swallowing of the toothpaste. Now, we mentioned earlier that children can swallow anywhere from 48 to 75% of what you put on their brush. And we mentioned earlier that there is an increase in fluorosis over the last 30 years in the United States. So there's a lot of questions that I get in our practice about when do I start brushing my children's teeth, how much toothpaste do I use a fluoride toothpaste, do I not use a fluoride toothpaste? And these recommendations, I think, can really help us understand what the ADA is recommending based on science. And now we've got a visual to accompany their recommendations. A grain of rice for children under the age of 3, a pea size for children ages 3 to 6. So I want to share that with you. I think it's a very important point, and I think it's going to help alleviate a lot of confusion. If you want to write or access or read the complete report, I've created a link down here that you can use. Okay, so let's look at the next condition, hypersensitivity. So the traditional home uses of products to treat hypersensitivity have been potassium nitrate toothpaste and, surprisingly, stannous fluoride gels and toothpaste. Now, we've already mentioned that stannous fluoride gives you caries protection, but then it also provides relief from sensitivity. And a lot of products have been on the market that contain stannous fluoride and been very effective for helping to reduce sensitivity. Next concern that we're going to discuss real quick is gingivitis. Again, different sources of products out there to help fight gingivitis. Stannous fluoride, again, another opportunity here. One product carries sensitivity in gingivitis. Other products on the market, fluoride plus triclosan, copolymer toothpaste. Many of you mentioned that you use Colgate Total. Very popular toothpaste. Very well known to help reduce gingivitis. Zinc citrate toothpaste also. These are all effective against plaque and gingivitis, but they all require the patient to use them, right, and proper oral hygiene. Okay, so let's take a look at this other concept that I think I want to try and help demystify for you if I can. We're getting into these new products, and calcium phosphate technologies keep coming up in a lot of questions that I experienced from my colleagues, including myself. So let's look at calcium phosphate technologies. What are they, and how can we understand them a little bit better? Well, right out of the gate, there's ACP, amorphous calcium phosphate, CPP-ACP, casein phosphopeptide, amorphous calcium phosphate, also known as Recaldent, CSPS, calcium sodium phosphosilicate, or Novomin, and tricalcium phosphate. So let's look at this. We'll start with ACP. Amorphous calcium phosphate is the first non-fluoride therapy to remineralize enamel and dentin. It was developed in 1991 by the American Dental Association's Paffenberg Research Center. And the idea here is that when calcium and phosphate salts are combined in just the right way, they form a solution that precipitates ACP. The ACP dissolves in enamel fluids and is transported into carious lesions where the calcium and phosphate ions precipitate and recrystallize as apatite to repair early carious lesions. What does that mean? It basically means that ACP works by enhancing the natural healing process of saliva, and it's been known to be a successful dentin desensitizer. How about TCP? Well, TCP fuses beta tricalcium phosphate and sodium lauryl sulfate or fumaric acid. This blending results in a functionalized calcium and free phosphate designed to increase the efficacy of fluoride remineralization. So rather than reading everything here, essentially TCP is another form of calcium phosphate technology. Then when it's combined in the right way, the fluoride and calcium react with weakened enamel to provide a seed for enhanced mineral growth and growth relative to fluoride alone. And then the next one I want to discuss is the casein phosphopeptide amorphous calcium phosphate. So this is a casein milk protein that was first investigated as a way to reduce caries. And it's referred to as a stabilized ACP and a complex of casein phosphopeptides that stabilize an amorphous form of calcium phosphate to maintain the calcium and phosphate ions, ensuring their delivery into tooth structure before they precipitate or crystallize. Now, I wanted to provide the definitions of all these products because a lot of times when I read this or see this, it doesn't sink in for me. So I'm trying to see if there's a way that I can help clarify some of this and demystify it for you. So essentially, does it really matter which calcium phosphate technology you recommend? Well, let's try and break this down and make it a little bit easier to understand. And I'm going to oversimplify it, and then we're going to get into a little bit more specificity. But I think by providing an overview, this might help us kind of get through that specific component a little bit easier. So which would you use? You just worked out, you just went bike riding, just played with your kids or your grandkids or whatever the case might be, and you're looking forward to a nice cold glass of iced tea, but you like your iced tea sweetened. Now, would you look for different sources of sugar? Now, Twizzlers contain sugar. Granular sugar and Twizzlers are your choices. Which would you put into that iced tea to immediately have sweetened tea? Now, we can put a Twizzler in and wait for the sugar to dissolve and maybe use it as a straw until you start to feel the sweetened sensation. Or if we use granular sugar, we will get an instant burst of sweetness to that iced tea. What we're really talking about is bioavailability. Now, bioavailability is the degree and rate at which a substance, in this analogy sugar, is absorbed into a living system, living in the sense of iced tea, or is made available at the site of physiological activity. Now, what does that mean in our analogy? It basically means which one goes into the solution of your iced tea and makes it sweeter faster. Obviously, the granulated sugar. So to understand what's happening here on the chemical level, we have to start with understanding atoms. And as an aside, and to break up this entree into a more difficult concept to understand, let's start with a joke. Why can't you trust atoms? Again, this is an internal poll. It's because they make up everything, right? So the reason I wanted to take that little break is because we are looking at chemical structures here. And once we start getting into chemical structures, my eyes glaze over. It gets a little bit too confusing, and I just need to kind of review this a couple of times. But let's look at the amorphous nature. What does amorphous mean? It means having no definite form, shapeless. So when you look at these two images, these atomic chemical structures, left is a hardly organized structure, that's amorphous. On the right is highly organized structure. So when we look at our analogy, the granular sugar is hardly organized. The Twizzler is more organized. Those atoms are bound up. They're not as bioavailable, which is why your iced tea wouldn't get as sweet if you put a Twizzler in there versus granular sugar. So the atomic structure we just mentioned, the granular sugar has the amorphous nature. The Twizzler has a more structured nature. That's as far as I can take that analogy because, unfortunately, the chemical structure of sugar is not relevant to what I'm going to show you next. But this is. And what I'm substituting the sugar for here is carbon atoms. And the reason that we're choosing these is a specific chemical structure. So let's look at this real quick. On the left-hand side, we see an amorphous chemical structure, coal. In the middle, we see a carbon in a layered pattern, which is the graphite in your pencil. And then on the right is a diamond, highly organized, highly structured. So when we look at our analogy between ACP and TCP and CCP-ACP, we want a product like sugar that's highly bioavailable, ACP. Amorphous in nature means it's highly soluble. Just like that sugar, when you put it into your iced tea, dissolves, instantaneously creates a sweet flavor. When you get to a more structured atomic structure like the graphite in the pencil, or in this case, TCP that we just mentioned, it's not as bioavailable. And then when you get to a highly structured product, it's very low solubility, makes it very low bioavailability. So as we look at this, we can see that on the left-hand side we have high solubility, which lends itself to high bioavailability. That's why sugar makes your iced tea sweeter faster in the granular form than in a form that's more structured like that Twizzler. So what does that mean for us overall? If you want a product that's highly bioavailable in a calcium phosphate compound, we want to look at the ACP technology. So the question comes back to us. That's our chemistry lesson, but what does this all mean to me and my patients, right? I mean, there's science, and then we have to interpret that science to make the best decisions we can for our patients. And a lot of this science gets complicated. And honestly, there's a lot of things going on in our practice that makes it difficult for us to take the time to really understand that if I want sweetened iced tea, I'm going to reach for granular sugar and not sugar that's locked up in a taffy or a Twizzler or rock candy, because it's going to take longer for that sugar to be available. That's what we're talking about with our calcium phosphate technologies. So let's look at the different calcium phosphate technologies on the market. We have sodium fluoride with TCP or Novamin. We have stannous fluoride with Novamin. We have sodium fluoride with CPP-ACP. And now we've got these new options. We've got stannous fluoride with ACP in a gel and a toothpaste. So let's look at what this means. One thing that we have to consider when we're trying to evaluate different products is compare one to the other, apples to apples, if you will. And one way to do that is to look at the FDA anti-caries testing protocol. All products that are manufacturers want to put onto the market must pass two of these three tests. A fluoride dentifrice product shall meet the biological test requirements for an animal caries reduction study and one of the following two tests, either an enamel solubility reduction study or an enamel fluoride uptake study. These are in vitro tests that must be completed before a product gains approval by the FDA and can be sold on the market. So this is a nice common ground to compare different technologies so that we can understand what the differences are between them. So let's look at what these tests intend to demonstrate. Their goal is to determine whether fluoride is chemically available from the product. Well, that makes sense, right? Because if this is a product that the FDA is asked to approve for fighting caries, it would make sense that we'd have to prove to the FDA that there's actually fluoride in this product that's bioavailable. Remember that term that we learned earlier? Chemically available, bioavailable. If it's in the product but doesn't release from the product, then it's not there to provide the anti-caries benefit. So let's look at a study that was just recently completed. What we have here is the 900 parts per million sodium fluoride paste with CPP, ACP. And on the left-hand side, we see the increase in enamel fluoride uptake into lesioned enamel. So what this is showing is that a product with CPP, ACP had a fluoride uptake of 316. A 5,000 parts per million sodium fluoride paste with TCP provided 4,138 parts per million increase in fluoride uptake. And this combination between that stannous fluoride that we kept mentioning and this ACP that we kept mentioning as the more bioavailable form of calcium phosphate provided more chemically available fluoride to the tooth structure. So if we go back to our iced tea analogy, our iced tea would be in the center here. On the left-hand side, we would have our granular sugar, and on our right-hand side, we would have our Twizzler. If the sugar is not available in that Twizzler to get into the tooth, then it's going to perform less, it's going to have a lower performance on this scale. If that sugar is more bioavailable, you're going to get a higher recording. And that's what we're seeing here. We're seeing a product with 150 amount of fluoride providing over 2 times more fluoride uptake than a 5,000 parts per million sodium fluoride toothpaste delivering TCP. Now that's interesting and that's worth investigating. Again, these are these are in vitro studies that can't infer clinical performance, but it's a one-to-one comparison that we can start to look at and say maybe there's more here. So let's take another look. How does this matter to our patients? Well, we talked about children aged 0 to 6 years and fluoride use. We talked about the increase in fluorosis. We talked about the fact that 5,000 parts per million fluoride and fluoride rinses are contraindicated for children under the age of 6. And the primary reason is what we talked about is that they can't expectorate all the product. They swallow a good portion, anywhere from 48 to 75% of what they put in your mouth, those kids will swallow or may swallow. So there's an increased risk of overingestion of fluoride and an increased risk of fluorosis. So what we're looking at is a pea-sized amount of the toothpaste, the 5,000 parts per million toothpaste, provides 1.25 milligrams of fluoride ion. Okay, so if we look at the IOM fluoride upper limit for daily consumption, this chart shows that children aged 1 to 3 should not consume any more than 1.3 milligrams per day of fluoride. Well, we're at 1.25 in a 5,000 parts per million fluoride toothpaste. A 970 parts per million fluoride gel that provided over 2 times greater fluoride uptake than this 5,000 parts per million toothpaste has 1/5 the amount of fluoride. So we're at 0.243, which isn't even on the scale. So So this is where things start to come together, and this is where things start to become interesting. So let's look at this other concern we mentioned earlier, dental erosion. If we can get more fluoride into the tooth by using a calcium phosphate technology, then perhaps that fluoride is not only going to reverse caries, or potentially reverse caries, we should say, or potentially help remineralize the tooth structure, but maybe it can help strengthen the enamel against wear. And we had mentioned dental erosion earlier. But let's look at dental erosion a little bit more. When we talk about dental erosion, there's a lot of different factors. We had mentioned the extrinsic and intrinsic sources of dental erosion. We had mentioned the fact that toothbrush and toothpaste abrasion can accentuate problems when you have softened enamel due to those extrinsic and intrinsic softening of the enamel due to acids. So the desirable features of preventive toothpaste or gel: effective, long-lasting, safe for all ages, but low abrasivity. Well, why is low abrasivity important? Let's look at this real quick. There's a short list here of products, and again, you can get the RDA value of all toothpaste and gels on the market. But we just took a sample here just to give you an idea. RDA value is relative dentin abrasivity. The FDA upper limit is 200. So that's what the FDA considers safe. But it's been highly regarded or known that the RDA scale of 100, above 100 is highly abrasive, and some say regarded as harmful above 150. Well, let's look at the numbers here. These numbers of the products that we talked about earlier are in that range. And when you look at that number and you couple in the fact of erosion and toothbrush abrasion and extrinsic and intrinsic sources of erosion, there's concerns that we might be able to address easily by helping those patients use different products at home. So then we look at the next level, mild abrasive, we have Sensodyne and Colgate Total. And then anything below 70 is considered low to mild abrasive. So one of the things that we can look at is the other study that's required by the FDA. Remember I said we can do either one or two of those studies. The first was the enamel fluoride uptake. The second was enamel solubility reduction. Well, let's look at the enamel solubility reduction study. And this is to demonstrate whether the fluoride contained in the product is available to be taken up by tooth mineral, and whether once taken up, it is in a useful form such that it reduces the rate of dissolution of tooth mineral when exposed to an acidic solution. Okay, so what does that mean? Again, the question here is, if the fluoride is available, which we've shown in the first study that it was, now we're going to say, well, if that fluoride is available, is it strengthening the tooth and making the tooth more resistant to demineralization, erosion, and so forth? That's what this second test does. So let's compare our numbers here. We're going to test the same group. So this research came out just this past year. 900 parts per million sodium fluoride toothpaste, CPP, ACP, provided 6.84% reduction in enamel solubility. Okay, again, we have our granulated sugar over here and our Twizzler over here. How much of that fluoride is bioavailable? We learned from the first test. This test is saying, of that fluoride that we determined in the first test was bioavailable, how much of it is actually strengthening the tooth? Well, we know here that the CPP-ACP strengthens the tooth 6.84%. TCP is 18.78%. But then we come over here and we're seeing 56% reduction in enamel solubility for the 970 parts per million stannous fluoride gel delivering ACP. Again, 1/50 amount of fluoride, but 3 times greater reduction of enamel solubility. Now we're on to something. Because if we can strengthen these teeth by increasing the amount of fluoride that we provide to them through this calcium phosphate technology, and then test to make sure that once that fluoride's there, it makes those teeth more resistant to acid challenges, now we have something to combat that erosion that gets perpetuated with a highly abrasive toothpaste to cause those lesions. Now, we talked about stannous fluoride providing anti-caries benefits, anti-gingivitis benefits, and then let's look at sensitivity. Now, there's two ways to provide sensitivity relief for our patients. There's potassium nitrate, which depolarizes the nerve, and then there are other products which occlude the tubules. So what we're looking at here is hypersensitive dentin, and we're looking at a cross-section of the dentinal tubules, and you've got your odontoblasts and an open surface because the cementum or enamel has been removed or worn away or eroded. Once that area is open, there's a communication between the oral environment and the odontoblast. Once that movement of water occurs, there's a stimulation of that nerve which transfers to the brain as pain. So calcium phosphate in the saliva can mix and create plugs that occlude these tubules. So let's look at this. That same stannous fluoride product that delivers ACP that we mentioned earlier also occludes dentinal tubules. So let's look at this scanning electron micrograph. What we're looking at here are those same dentinal tubules. And what we're starting to see after 1 day of brushing, 2 applications, we're starting to see this precipitate. And what we notice is after 5 days of brushing, this is again an in vitro test, we start to see that these tubulars are completely occluded. Now, this is very interesting because, again, we're looking at a stannous fluoride product that's delivering ACP, that's providing greater fluoride protection and reducing the enamel solubility of the tooth structure, but also occluding dental tubules. So these are studies that we're looking at that are intriguing and helpful and potentially help us to understand what other opportunities might be out there for our patients. So let's review this. So the stannous fluoride product delivering ACP. Well, we know the stannous fluoride reduces dental caries. Check. We know that the stannous protects against acid challenges, is antimicrobial, and occludes dental tubule. Check. And we know that the amorphous calcium phosphate increases the fluoride release and uptake, works with stannous fluoride to increase fluoride uptake and reduce enamel solubility, and helps to occlude tubules. So before we had mentioned earlier in the program the desirable effects for efficacy, we want something that increases the protection against caries. We want something that reduces enamel solubility against acids. We want to provide something that relieves dental hypersensitivity. We want to protect against gingivitis, and we want it to be safe and effective for children and adults. So these are things that I think about when I'm trying to determine what products to recommend for my patients. Then you get into your specific risk patients, right? Those who have significant problems that require maybe a little bit more protection. Well, I think of orthodontic patients right out of the gate. You know, we always have a challenge there with compliance. Compliance across the board, but I've got 2 braces right now, and we all know how that goes. So our goal there is to straighten the teeth, but we want to make sure that we prevent those white spot lesions, and controlling gingivitis is the first step in that process. So for providing a product that can do both in one tube definitely helps with compliance. Now, pediatric patients, childhood caries and erosion. We shouldn't have fluorosis on the rise. We've had early childhood caries on the rise, although recent research suggests that perhaps we've gotten a better handle on that. But those erosive lesions that I showed you earlier, I think we can all agree that if there's something we can do to help prevent that, there's definitely science and technology out there that's working towards us. It's just a challenge for us as dental professionals to find the time and the resources to actually understand which products might be most beneficial to our patients. And then for our adult patients, the prevention of root caries and coronal caries, gingivitis, increased sensitivity. We mentioned the onset of sensitivity for a lot of patients is between 30 and 45 years of age. Increasing resistance to acid challenges. We certainly can see as our patient population demonstrates, there's a wide variety of challenges that we're faced every day with, and trying to find a solution that matches each one can be frustrating and time-consuming. So let's wrap up, and let's look at what we can summarize here from our program. What is an appropriate recipe for a dentifrice? If we had to find one that was an all-in-one, what would that look like? Well, we would definitely want excellent fluoride uptake and resistance to enamel solubility. That helps us against caries, erosion, both extrinsic and intrinsic sources of acid challenges. We didn't really mention too many sources, but intrinsic sources of acid challenges are your acid reflux, your GERD, patients that have a lot of acid produced internally that is exposed to the oral environment. Extrinsic sources, sodas, pH products that contain a low pH, any of those products that we take externally and bring into our oral environment that can cause erosion. Product that can help in both of those regards will be very well received. Effective occlusion of dental tubules to treat sensitivity, great feature in a product. Extra protection for young children and adults, nice combination there to be able to cover both. A safe and effective alternative to 5,000 parts per million fluoride products. Prevent caries, reduce gingivitis, and treat hypersensitivity with one product. So in conclusion, I just want to thank you for sharing your time with me.